Welcome everybody to this seminar of the DRO. It's a great pleasure to introduce Masud Husain. I think most of you know him very well already. He's a professor of neurology and neurocognitive neuroscience, and he is, of course, a well-known leader at the BRC in Oxford, but also he is the co-lead of Dementia Research Oxford. And we all know him as well as the editor-in-chief of Brain. So starting a bit late, I would say we start with the presentation, Masud, when the spark goes out. Go ahead.
Thanks. Thank you very much, Cornelia. Yeah, and thank you, Nick, for organizing this too. So before I start, I just wanted to thank our funders, the Wellcome Trust, who've been funding us for the last 23 years, and NIHR through the Biomedical Research Centres at Oxford. And I also wanted to thank all the people who've been involved in the work I'm going to show you. I'm really standing on their shoulders here to describe the stuff that we've done. And this is going to be quite a general talk. So although I'm going to be talking about apathy in neurodegenerative diseases, I hope there'll be something here for everyone, even people who may not be working on neurodegenerative diseases. And I wanted to start really with the subject of motivation, because it's something that I hadn't really considered in great detail until about, I don't know, about 12 years ago. And it's made me think a lot about motivation in ourselves as well as in patients. So we all know that we've got acquaintances, we've got friends, we've got family members, we've got colleagues who vary enormously in their levels of motivation. There are some people like this. This is a character created in Russian literature by Ivan Goncharov, a character called Oblomov, who spends all his day lying around, not really making any decisions, and the serfs are pulling out their hair because their master is not really taking any kind of control over the estate. He is the ultimate chaise longue potato here. We know people like this who are extremely apathetic. And then there are other people who say, yeah, I'm going to run up that hill for you, whatever you say. Put a backpack on me and I'll do it for you. So all the people we know have these various levels of motivation, from apathy all the way to highly motivated. But I really got involved in this, thinking more deeply about this, about 12 years ago when I was at UCL, at the National Hospital for Neurology, and we received a letter about a guy in his late 30s. And the GP's letter said that he'd had some unusual stroke 6 months ago. He'd recovered physically really well, but he was a completely different man. Before this stroke, he'd been highly motivated, he'd been very sociable, the center of his crowd, but now he really couldn't even be bothered to work properly. And this guy turned out to be really interesting because he'd not had one stroke, but two. You can see them here. These are these two tiny little dots here in the basal ganglia. And understandably, his GP had thought, well, maybe he's just become depressed after his strokes. But that didn't turn out to be the case. You know, he was treated with antidepressants. It didn't make much difference. And actually, psychiatrists who'd seen him subsequently also thought he wasn't depressed. So he had suddenly turned into this very, very inert, amotivated person. Unsurprisingly, he lost his job because his employers didn't really find that he was doing anything useful. But he was so lacking in motivation that he couldn't even be bothered to get unemployment benefit. And he had some very good friends who said, well, why don't you move in with us for a little while? They promptly regretted making that offer because all he did all through the day was just sit there waiting for them to come home, for them to do his cooking or cleaning or whatever it was. And understandably, they regretted having asked him to come to see him. But these two little strokes are actually in the ventral parts of the globus pallidus. And there are other reports in the literature of people who can suddenly become very, very profoundly apathetic following such lesions. It got to the point when we saw him that we asked him, why do you sit there all day? What would you really be doing otherwise? And he said, well, I would love to listen to music. And why aren't you? Well, it would take me a little while to put my music system together. How long would it take? 5 minutes. So this was the level of profound apathy that had developed in this relatively young man following these two critical basal ganglia lesions. So what about the basal ganglia? How are they involved in motivation? And here, I'm just going to bring together probably 3-4 decades worth of work and give you my view of the fact that the basal ganglia's contribution to motivation is partly through its links with the prefrontal cortex. So we know that the ventral tegmental area, here shown in green, which really runs into the substantia nigra complex, projects to the pallidum and the basal ganglia. And the basal ganglia, in turn, has reciprocal connections to prefrontal cortex, including ventromedial prefrontal cortex and the anterior cingulate, which again send projections back to the basal ganglia. And it's turned out this circuitry, which links the VTA, the ventral tegmental area, to the basal ganglia and the prefrontal cortex, that's been implicated on many, many occasions in terms of the process of motivation to action. This is interesting because dopamine has been identified as being a key neurotransmitter in the modulation of such motivation. And of course, that might be very interesting because we know that pathology that affects the substantia nigra complex can lead to the movement disorder of Parkinson's disease. What I'm going to show you later on is that it can also lead to profound apathy. But what about the basal ganglia? Why is this such a key node? Well, perhaps one clue comes from thinking about the evolution of the basal ganglia, because the first organism in evolution really to have any kind of basal ganglia is the lamprey. This is this creature which has been on Earth for more than 500 million years. It's nearly became extinct in the UK, but it's been restored, and it's quite a frightening thing. If you look very, very closely, you wouldn't want to get too close to a lamprey. But it has survived for so many millennia. And the work on the lamprey has suggested that the basal ganglia are a key node for organizing motivation to action. That's movement in the service of motivation. But motivation for what? Well, in the lamprey, this is motivation for food, for water, for sex. But it turns out a lot of work in humans has suggested that that common circuitry which links the VTA to the basal ganglia and prefrontal cortex is also a common circuitry employed for motivation in us. Motivation when we're hungry, when we're thirsty, when we're seeking sex, drugs, whatever it is, whatever kind of action that we're performing to get a rewarding outcome. And a couple of things are important here to think about, because if you think about the process of hunger and think, what is that? Because, you know, if you miss a meal, you're not going to die. But why do we get this sensation of hunger building up? It's an urge. It's a motivation signal to go to seek something which will reduce that hunger, to go and open the fridge, to open the cupboard, whatever it is. So hunger is a common motivational signal that's present in many organisms. And it turns out that a completely different field, the field of addiction, has also come to the conclusion that this circuitry linking the VTA, basal ganglia, and prefrontal cortex is the one that appears to be hijacked by drugs which lead to substance abuse. So on the one hand, if you take out a bit of this circuitry, you can get profound apathy. On the other hand, there's a whole literature out there which suggests that hypermotivation to seek drugs, for example, might also use this same circuitry. And finally, dopamine, which we'll come back to during this talk, appears to be a key modulator of this motivation, because too much dopamine has been shown in various different contexts to tip people into impulsive behavior to seek rewards that they might otherwise not seek. So this seems really interesting. We've got this circuit, which on the one hand can lead to apathy, on the other hand to impulsivity. So many years ago, when the work on dopamine was being done, it was suggested that actually what dopamine is a pleasure chemical. Too much pleasure can lead to addiction to substances that might give you that high. But actually, more recently, the work has suggested that actually dopamine doesn't give you the hedonic response, but rather the motivation to seek a hedonic outcome. And this is a nice piece of work which was published last year, which is on honeybees. It's interesting that the same mechanisms work throughout evolution, but honeybees obviously go to seek food. They come back, they do a dance to let others in the hive know where that food is. And here, these investigators measured both dopamine and serotonin in honeybees and found that actually the highest levels of dopamine was when the bee arrived at the food source and when they went back to tell their mates in the hive about the food source, but not actually when they were feeding. So the inference here is that high levels of dopamine are all about that excitement, the motivation to seek pleasure for rewarding outcomes, rather than actually the hedonic response, the pleasureful response obtained from getting the outcome. And in rats, this is some work done by John Salamone in the States. If you put a rat into a tea maze here and give them the choice of bland laboratory chow or of high-calorie food on the other side, but they need to scale a wall in order to obtain that high-calorie food, many rats are willing to put in that physical effort to get that rewarding outcome. They'd rather go here than go for the bland laboratory chow. But if lesions are made, either in terms of depleting the rat of dopamine from the ventral striatum or the nucleus accumbens, or if medial frontal lesions are made, as was performed here by Mark Walton and Matthew Rushworth, the rat is no longer interested in making that effort to get to this rewarding outcome. They'll go for the bland laboratory chow. So dopamine in the basal ganglia and medial frontal cortex appears to be important nodes in the decision-making of whether a particular reward is worth the effort required to obtain it. And it also turns out that functional imaging studies in healthy humans have shown that we also have regions of the brain that are responsive to potential rewarding outcomes, and these include the ventral parts of the basal ganglia, the ventral striatum, the equivalent of the nucleus accumbens, and the ventromedial prefrontal cortex. And there are other regions which are also encoding the level of effort required to obtain a particular reward. These include the dorsal anterior cingulate and the anterior insula. And this nice review by Matthias Pesiglioni in Brain a few years ago describes the circuitry that might be involved when we are making an assessment about whether a particular rewarding outcome is worth the physical effort required to obtain it. So that circuitry that links the basal ganglia to the prefrontal cortex might be very important in motivation to action, but particularly for making decisions about whether a particular action is worth the physical effort. So with that in mind, when we saw our patient with the basal ganglia lesions, we decided to try some experimental medicine here by giving him levodopa to see whether dopaminergic stimulation might lead to an improvement in his apathy. It turned out it didn't, but we didn't give up hope there. We then decided to try a direct dopamine receptor agonist in the form of Ropinirole. This is a drug that we use in Parkinson's disease, but here we were trying to see whether direct stimulation of dopamine receptors would lead to an improvement in motivation. So this guy, who we'd seen in a very disheveled state, he wasn't really looking after himself, he wasn't really taking a bath or a shower, he really wasn't doing very much for himself, came back to us 3 months after starting Ropinirole in a very, very different state. He'd come in a suit, he'd had a haircut, he'd got a job, and the most surprising thing was that he'd managed to get a girlfriend, because before this time, he really wasn't meeting anybody, but now he was motivated to act. So he is obviously clearly a very unusual character. These kind of brace of strokes symmetrically in the basal ganglia, this is a really unusual thing. But it turns out that apathy like this is very, very common in neurodegenerative diseases. In Alzheimer's disease, Parkinson's disease, small vessel disease, which leads to vascular dementia, frontotemporal dementia, stroke, traumatic brain injury, roughly 1/3 of all patients suffer from pathological apathy, pathological loss of motivation once they've developed the disease. And in this talk, I'm going to focus a bit on Parkinson's disease, because here we can modulate levels of dopamine, and also in a very important condition, small vessel disease. But it's not just in these common conditions. There are lots of other neurological conditions, some associated with neurodegeneration, in which apathy is a profound problem. So the question is, although these different diseases might have different underlying molecular pathologies, is there a common circuit level explanation that might be explaining the generation of apathy in these patients across different conditions? So how do we define apathy? How does a clinician define apathy? These are the latest criteria. It's a syndrome characterized by reduced motivation with reduction of goal-directed activity. And it's acknowledged now that there might be reduction of goal-directed activity in different domains. It could be behavioral or cognitive, it could be emotional, it could be social, but it's all in comparison to the patient's previous level of functioning. And it's been suggested that probably need to have 2 out of those 3 domains to be affected to really qualify for this diagnosis. And most importantly, it's got to be clinically significant, either in your personal life, social or occupational life, like the patient I showed you who no longer was able to do his work. And it's got to be the case that the symptoms are not due to some other problem like a physical or motor disability, or in fact, substance abuse. A few years ago, I was putting this slide together, and my then teenage son was looking over my shoulder, and he said, "Well, that's just too much text, Dad. It's far too much text." And I said, "Oh, okay. How would you put it then?" And he suggested that perhaps the best way to think about this is CBA. It's probably an interesting way to consider what these criteria mean, but essentially these are people who have lost their motivation. They really can't be bothered. To give you an idea of this, I'm going to show you a little conversation I had with a patient of ours who's given permission for this, and she's talking about the fact that she can't be bothered anymore, and she's talking also about her husband, who has become very frustrated that she can't be bothered anymore. If I was a fly on the wall, watching you at home, what would I see you doing during the day?
I suppose sitting, watching television, which drives him mad. I did used to book read, but I don't seem to be doing that much these days. And that's basically it, really.
So watching the television. Yeah. Anything else?
Can't think of anything, really.
In the past, would that have been you?
No.
What would we have seen? If we'd been a fly on the wall a few years back, what would we have seen?
Me buzzing around, doing things, going out shopping, coming back, being busy all the time. and I just slowed down and more or less come to a halt, really.
Yeah. And you said you used to enjoy reading.
Yes.
So what's stopping you reading?
Absolutely nothing. Just that I can't be bothered, I suppose.
Mm-hmm.
It's easier to watch the screen and read a book. I keep threatening to pick up a book, but I just don't get there.
Some of my students have actually said the same thing from time to time. One of the issues about apathy is it's sometimes really difficult to distinguish from depression. You can imagine that if someone is looking amotivated, there might be many reasons why that might be the case, including some problem in terms of their mood. But here is a study, for example, performed in Parkinson's disease patients, looking at those with depression on the left here and without depression, formally examined by psychiatrists. And you can see that while there are people who have both depression and apathy, there are also others who are not depressed and nevertheless apathetic. And like our patient I showed you earlier, who actually wasn't depressed at all. He was quite happy. He didn't have any problems about thinking about the future. He didn't have any bad thoughts about the future, but he was nevertheless lacking in motivation. So an important point here is that there are patients who have pure apathy, but there is also an overlap with depression. The second thing that might be useful to think about is that there are different domains of apathy, and these domains can be differentially affected in neurodegenerative conditions. Here's a study we performed in Parkinson's disease a few years ago, and we're looking here at the behavioral, social, and emotional domains of motivation. And you can see in this graph that Parkinson's disease patients show significant levels of apathy on the behavioral and social domains, but actually there's no significant difference in the emotional domain. So there can be differences across these domains. Most of the work that's been done to date on apathy, however, has been on the behavioral side. So we need to examine in much more detail what happens with motivation in social and emotional domains. So how do we explain all this? How is it possible for someone who was very, very motivated suddenly to lose their motivation just like that, and somehow also have that motivation restored by giving them a dopaminergic medication, as in the patient I showed you? We thought about this quite long and hard and decided that we'd just go back to the drawing board and think about the components of behavior leading to motivated action. So this is a schema that we proposed, which goes all the way here from option generation through an evaluation of whether it's worth the effort, to motivational arousal, engaging with the motor machinery to initiate action and also persist with action, the response in terms of interacting with the behavioral goal, whether it was a positive response or whether actually it turned out to be a really bad action to perform, and learning from those outcomes so that we can change our weighting of how we evaluate whether something might be worth the effort or not in future decision making. So we looked, first of all, at option generation. So imagine that there's a person who you ask, think about what you could do today. Give me all the possibilities about what you could do on a nice sunny day like this. And if they aren't even able to generate those options for behavior, it might be that's the reason why they appear to be lacking in motivation. Could it be that one component of lack of motivation is actually the inability to generate the options for behavior? So we looked at this. I won't go into the details. We used a very, very simple task, which is effectively a non-verbal fluency task. And here on the x-axis, you can see the motivation score, self-reported motivation score on a questionnaire measure in young people that we tested, and the number of options they were able to generate on the task we gave them. And we got very excited because there was very strong correlation between self-reported level of motivation and the number of options generated within a fixed amount of time. So this is in healthy people. But we also did this in Parkinson's disease, and we looked at patients with apathy and those who are normal in motivation. And slightly to our disappointment, we found that actually option generation is actually not related to apathy in Parkinson's disease. Apathetic people with Parkinson's disease can generate just as many options as those who are motivated. We were disappointed, but it's a clear-cut result. At least we know that that isn't the problem that's underlying their apathy. So the second thing that we've looked at, and this has turned out to be far more rewarding for us, is this cost-benefit decision-making. The ability to evaluate options according to whether they're rewarding enough for us, given the effort required, or given the time required, or perhaps given the risk that's involved in obtaining that potential reward. So we did this in a very simple way, but just to make sure that you're on the same page with me, what we're thinking about here is that the subjective evaluation of effort and reward, they differ enormously from person to person. Right at the beginning of the talk, I mentioned that we know all these people who vary in their levels of motivation. You know, people who are extremely motivated, and you know, people who are quite apathetic. So there are people who think a particular type of action that's required is nothing. I can do that. That's easy. It's something I can run up, no problem. And then there are people like Oblomov who thinks everything is a huge hill to climb. I'm not going to do it. I'll just lie here on my chaise longue. In my own home, I don't know if it happens in yours, everyone's motivated to bring the crockery back to the dishwasher, but seem to lack motivation to open the dishwasher and put it in. So that part of the process is far too much an obstacle for them to climb. Okay, so how do we look at this in an experimental way? We did this with a very, very simple task where on a trial by trial basis, we're presenting you with a particular rewarding outcome. And this is shown here as the number of apples in this tree. The number of apples will translate eventually at the end of the task into a monetary reward. And in order to get this amount of reward, you have to put in this amount of force, and we'll vary the amount of force and reward that we offer you. So here I'm showing you so many apples, and the yellow line on the tree tells you how much force you have to exert to get it. And this is scaled to your maximum voluntary contraction. So here's how it might go. If you say no, we'll give you another offer. If you say yes, you have to squeeze to get this dynamometer up to that level of the yellow line. So we have this neuroeconomic space where on one axis, we've got different levels of reward, and on the other axis, we've got different levels of effort. So here we can just probe on all these different permutations and see where someone is prepared to work. So here's the data from one individual, and you can see in yellows where they were willing to say yes very, very often, high reward, low effort. But in blues, right up here, you can see that when the reward is low and the effort is high, they're less inclined to say yes. So this gives us really a matrix to look at the space in which people are willing to put in the effort for different levels of reward. So we asked the question about how this might work in apathy. Is apathy associated with reduced sensitivity to reward, or is it the fact that people who are apathetic are hypersensitive to effort? Of course, it could also be both. We did this first in Parkinson's disease. So we've got this space, different levels of reward, different levels of effort. And here you can see that the total proportion of offers accepted by Parkinson's disease with apathy, shown here in red. Let me just get this. Yeah, shown here in red, is much less than the number of offers accepted by Parkinson's disease patients without apathy and also with healthy age-matched controls. So apathetic patients are less inclined to say yes overall. And if we look at the level of apathy on a clinical scale here, compared to the proportion of offers accepted, you can see that there's also a very strong inverse relationship. The more the apathy, the less inclined you are to put in the effort. So this is an overall glimpse at behavior. But what about looking at this in more finer grained detail? So we've got our space, and now I'm projecting this in a sort of three-dimensional representation, and I'm looking at the difference between patients who are motivated and those who are apathetic. So if there was no difference between them, we would just see a flat manifold here in terms, it would really just be on that gray floor you see. But there is a difference, okay? So here's different levels of reward, different levels of effort. And if we subtract the apathetic people from the motivated people, we see that there is a difference, but it's a difference in one part of this neuroeconomic space. Motivation patients are willing to accept more of the low reward offers. When reward is high, everybody's willing to work, whether you're apathetic or not. But the difference between the motivated patients and the patients who are apathetic is at the low rewards. Now, because this is Parkinson's disease, we were also able to look in a counterbalanced manner at patients on their dopaminergic medication versus off their dopaminergic medication. So we could ask, does dopamine make any difference to the choices that these patients make? And it turns out it does. So here again, we're plotting that space, reward and effort. And you can see that when patients are on dopamine, they are more willing to accept offers, but crucially at the high effort, high reward end of this space. So clearly, dopamine does make a difference. Just being on your dopaminergic medication changes the willingness to work, but it does so at a different sector in this space than the difference between motivated and apathetic individuals. So this is important because it suggests dopamine is a key modulator in this kind of effort-based decision-making for rewards. But maybe the difference between motivated patients and apathetic patients isn't all due to dopamine. They all have Parkinson's disease. The difference between the motivated and apathetic patients appears to be at a space where it doesn't correspond to the effects of dopamine. So I'd like you just to bear that in mind, because this is one piece of evidence that suggests that although dopamine really does modulate effort-based decision-making for reward, there might be another reason why motivated patients differ from apathetic patients with Parkinson's disease. So we used a trans-diagnostic approach. Remember, I was saying that what we're interested in is, could it be that across different molecular pathologies, the same circuitry might be affected to lead to apathy? So our next port of call here were patients with small vessel disease. Now, normally, small vessel disease is most commonly associated with high blood pressure, diabetes, smoking, high cholesterol, and so on. It's something that's really very common as people age, and it leads to these changes that you can see here. The white you can see on these MRIs are confluent areas of small vessel disease. Sometimes you can get little small strokes like this little lacunar infarct here, shown in this with in black here. And we looked at two groups of patients. First of all, we looked at patients with something called CADASIL, which is a genetic condition that leads to small vessel disease. It's an autosomal dominant condition which leads to small vessel disease. And we looked at them first because these patients develop symptoms of apathy in their 30s and 40s and are unlike to have any other kind of coexisting pathology that occurs with age, such as, say, Alzheimer's disease. And to cut a long story short, when we looked at their performance on this task, we found exactly the same behavioral signature of apathetic patients being less willing to work than motivated patients when the rewards are low. So in CADASIL And in Parkinson's disease, apathy is associated with this less inclination to work for low rewards. We also did this in the common late-onset small vessel disease. These are people who have high blood pressure or have been smoking or have diabetes. And here we're plotting what happens with increasing reward and increasing effort. And you can see that, yeah, if we compare apathetic people to motivated people, we get, again, the same blunted sensitivity to low rewards, but at the high rewards, everyone's willing to work. But in these patients, if we're plotting effort against the proportion of alphas accepted, we can also see that there is an element of hypersensitivity to effort. When the effort required is high, apathetic patients are less inclined to say yes. All right? So in this case, it's not only this blunted sensitivity to reward, there is also some evidence of hypersensitivity to effort. And because small vessel disease patients have quite marked changes on their MRI scans in terms of the white matter tracts, we could look at those and compare patients with apathy with those without. And you can see that patients with apathy have differences in terms of the fractional anisotropy of the anterior cingulum, as well as the anterior limb of the internal capsule. And this particular pathway links the basal ganglia to the medial frontal cortex. So this is further evidence for that circuitry linking basal ganglia to medial frontal cortex being important in the generation of apathy. And interestingly, if you did this for patients who are depressed versus those who weren't depressed, looking at the same group of people, but just shuffling them in terms of whether they're depressed or not, there were no specific white matter tracts associated with depression, but there were with apathy. Okay, so we've looked at option generation and we've looked at cost-benefit decision-making. Our next area was looking at this issue of motivational arousal. So here is a cat and it's waiting to pounce on a little bird in the garden. If you look at its eyes, you'll see that the analog of its pupils are dilating in anticipation of the rewarding outcome. Now, it turns out that actually humans have a very, very similar motivational arousal signal, autonomic motivational arousal signal, and that we can also tap into this by measuring the pupils and their anticipatory dilatation for a rewarding outcome. So this is a task. I get you to look at the center of a screen, and this disc is going to move either to the right or the left. And before each trial, I'm going to tell you whether there's any reward on offer or not. And it could be no reward, 0 pence, or it could be a high reward, 50 pence, or it could be a medium reward, 10 pence. And on this trial, your job is to make an eye movement to the disc, either to the right or the left, as fast as you can, because the faster you get there, the higher the reward you get. So this is our incentivization for you to move quickly. And on this task, what we find in healthy people is that the pupils are dilating well before any eye movement is made in anticipation of the reward. So if the reward is high, the pupils dilate more than if the reward is low. And this is in healthy people. So what happens in apathy? Here are the data in patients with Parkinson's disease. You can see here that the level of pupil dilatation in non-apathetic patients is good. So before the eye movement, their pupils are dilating. But in apathetic individuals, there really is this blunted sensitivity to reward. They're not showing that motivational arousal that motivated patients show. Okay. Now we can look at this in patients with Parkinson's disease on their dopaminergic medication or off it. And we can look at that in apathetic individuals, here shown in cyan, and in the non-apathetic Parkinson's patients, and compare them also to healthy elderly controls. You can see that when patients are on their dopaminergic medication, the dilatation of the pupil is much bigger than when they're off their dopaminergic medication. But look, this occurs in both the people who are apathetic as well as the people who are motivated. Although the baseline is different, it's the same gradient. So again, dopamine can modulate motivational arousal in Parkinson's patients, but it doesn't discriminate between whether you've got apathy or not. So this is a second piece of evidence suggesting that, yes, dopamine is important in motivation, but it may not be the full explanation for the difference between apathetic and non-apathetic patients. So what might be the difference? Well, I think we have a little clue here, and I'm going to show some final data here in a condition called REM behavioral sleep disorder, RBD. So normally, when we sleep and dream, we're atonic, we're really effectively paralyzed. But there are individuals who develop a condition called REM behavioral sleep disorder. And these people are no longer paralyzed when they're dreaming. So they enact their dreams. And they're usually brought along by their sleep partner to our clinics because they've been enacting their dreams. They've been screaming and shouting. They've been trying to physically assault their partner because they're having a dream and they're enacting those thoughts they're having in their dream. But it turns out that that's not the only problem in RBD, because it has a high risk of developing Parkinson's disease or a Parkinsonian syndrome. In fact, that risk is of the order of 80 to 90% within the next 10 years. So it's an enriched cohort of people who are at very high risk of developing Parkinson's. So with Tom Barber and Michelle Hu at Oxford, we looked at patients who have RBD, and we found that clinically, actually, 45% of them have apathy. Remember, they haven't even developed Parkinson's disease yet, but nevertheless, they have this loss of motivation, which also will occur in Parkinson's disease. Now, Tom was doing a series of DAT scans, the dopamine transporter scan, in these patients. And you can see that DAT scans show us the level of dopamine transporter and the level of presynaptic dopamine, if you like, in the basal ganglia. You can see the basal ganglia lighting up beautifully here. But the ligand, which links to the dopamine transporter, is not super selective. It also links to the serotonin transporter. And here you can see that actually it can bind to the serotonin transporter in the dorsal raphe, the important brainstem nucleus for 5-HT. And what Tom found here was that there are some patients who show very high signal in the dorsal raphe, but there are others who show very low signal in terms of binding to the serotonin transporter. And moreover, the level of apathy on a clinical measure correlated inversely with this level of binding. The greater the level of apathy, the sparser the binding. So this raises the possibility that actually, although dopamine might be a key modulator and may be very important in apathy, there might be other neurotransmitters, even in prodromal Parkinson's disease, other neurotransmitters like serotonin that might be contributing to the genesis of apathy in these patients. I think we're in early days here, but one thing I think that's become apparent is it's not just dopamine that's a key neuromodulator leading to apathy. Okay, so I've come to the end of my talk, and I hope you've got interested in this, and I hope I've shown you that there is actually a biological system that's dedicated to motivation to act. It's been conserved over evolution, and it involves the ventral tegmental area, the basal ganglia, prefrontal cortex, and their connections to each other. And that one thing that we've learned is, yes, perhaps lacking in dopamine here might lead to loss of motivation. Too much dopamine can lead to impulsivity. But although we've looked at apathy across neurological disorders and found that there might be a common signature across disorders where there is blunted sensitivity to reward. Perhaps dopamine isn't the only thing that's involved here, because as we've seen, although dopamine affects reward sensitivity, it doesn't discriminate between patients who are apathetic and who are non-apathetic. And the last bit of evidence, as I showed you, is that perhaps there are other modulators like serotonin, which might be contributing to the syndrome of apathy. Okay, thanks very much. I think you're muted, Cornelia.
Sorry for that. I was just summarizing that if you have a question, do put it in the chat, and there's already 2 in the chat. The first question was of Nick Wilcox, I think, and that's about whether Ropinirole acts by reviving dormant pathways or alternative ones, or it just by souping up their last remains. Can overdosing lead to disasters?
Yeah, there are many questions there, Nick. Yeah, I mean, I don't know how Ropinirole acted. It's possible that it was acting on preserved dopaminergic receptors in the basal ganglia or in the prefrontal cortex. My hunch is actually it's more likely the prefrontal cortex. So we don't know for sure. Can overdosing lead to disasters? Yes, it can. We've had those experiences ourselves. So we have to do this very cautiously, because in other patients, we've done this. There was a patient I remember very well who wanted to lose weight. He'd gone onto the internet and decided to get medications from there. He was losing weight because what he was taking was thyroxine, which increases your metabolic rate. But unfortunately, he had an out-of-hospital cardiac arrest through this. Prolonged resuscitation, 1 hour of resuscitation, but he survived, but he was left with profound apathy. We were able to restore his motivation slowly by increasing Ropinirole, but his wife felt that he wasn't still quite right. So we increased it even further, but we made him very, very impulsive. It became very pathologically impulsive, and we had to bring that dopamine level down again. So this is well known also to clinicians who look after Parkinson's disease, that you can tip people into impulsivity. So yes, overdosing can lead to disasters.
Thanks a lot. So I echo that. That was a wonderful talk, of course. And Junji has a question on that and about how to differentiate apathy and depression in the clinical setting rather than in the research setting.
Yeah.
Came to my mind too.
Yeah, well, I think if you're a good clinician, what you do is you do that not with questionnaires, but through interview. You know, you talk to the patient, you talk to their relatives, and you get a feeling of whether actually, you know, they have dysphoria, whether they're sad, and what they're thinking about the future is. And I've seen these patients with pure apathy who are very happy. They don't mind sitting there waiting for their friends to come home and do all the work for them. You know, they're not low in mood. So actually, you can do it. It can be sometimes difficult if there's an overlap. I think that's where the difficulty is. But there are clearly people who are apathetic but quite happy. And how you distinguish this in the clinical setting is you do it through the interview.
Thanks. We have another question. So one from Faisa. Can't read your names well. So, but the question is, can you elaborate on your thoughts on transdiagnostic criteria? RDOC, how would someone on cocaine, amphetamines perform on these three?
Yeah. Transdiagnostic criteria. I think that's really important because it's clearly this syndrome is common across many, many different disorders. And of course, it's possible that there are each particular disease has its own type of apathy. I would be really surprised if that's the case. I think there might be differences in terms of, as we showed you, some patients might be more hypersensitive to effort than losing sensitivity to reward. But I'd be really surprised if it's that heterogeneous. And in the first instance, the hypothesis is there are actually common features of apathy across different conditions. So that's the hypothesis that we're testing. And I've shown you examples of how we're trying to do that. The RDoC criteria are actually a very similar way of thinking about this, because the thinking there that NIH produced these criteria is to think, okay, look, the level of clinical description is missing something. For example, there may be components of depression that overlap with apathy, but on the other hand, there may be people with a constellation of particular components, behavioral components, who have only apathy, whereas there may be another constellation of components which lead to only depression. Another one might be a common overlap between those. So the RDoC criteria are a way to try and fractionate syndromes in terms of their underlying cognitive or behavioral components. So I think in many ways, it's a laudable effort. The question is, do they have the right tools to make those components visible in terms of the testing they do? And your final thing is about amphetamines and cocaine. I do not know, and I'm not sure anybody has done this yet. We've performed a study in schizophrenia using this task, but we've not done this in patients with substance abuse disorder. The question is, it's complex, because my understanding of many people with substance abuse disorder is that they can actually have both. They can be apathetic and impulsive. And I don't have time for this today, but we're also finding that very similar connection between apathy and impulsivity in neurodegenerative conditions. For example, in frontotemporal dementia, you can have patients who are impulsive one moment, very apathetic the next. Yeah, I should move on to the next question, I think.
Thank you. Yes, there are a couple of more, Masud. So Aida Suarez is asking any evidence of behavioral interventions that show promise on treating apathy in people with neurodegenerative conditions.
Yeah, there isn't. We did get involved with a group who are very interested in looking at this, and I think there's definite potential. For example, behavioral activation therapy might be an important way to do this. So having a very structured kind of regime and giving people rewards for achieving those outcomes. So yeah, this is an open space, actually. So there isn't any evidence at the moment.
All right, thanks. Another question for Michelle Nassen. So thank you for a really engaging and interesting talk. I was wondering if you could perhaps comment on the link between apathy and impulsivity in some neurological conditions. How would you explain their co-occurrence under a dopaminergic net framework?
Yeah, and I think, okay, so let me try and give you some idea about how we're thinking about this. So I mentioned that there might be more than one domain of motivation. So just thinking about a circuit which is either on or off, you'd think, well, that's a bit difficult to explain how you could be impulsive and apathetic. But if that circuitry actually involved different domains, then it's possible for someone to be on in one domain and off in another domain. So that's one possibility. Of course, the other possibility is this circuit is actually flickering. Sometimes it's on like a flickering light, and sometimes it's off. And is that a reason for the dysfunction? But both of these things are really interesting possibilities, because as I alluded to, there are not only neurodegenerative conditions, but our own work in healthy people. Large data sets show that self-reported apathy correlates very strongly with self-reported impulsivity. So I think there's a really important clue here about why those two things correlate, but we don't know the answer.
All right, two more questions from ZA. My question is about apathy, bimodal motivational states, and reward effort sensitivity in ASD and ADHD. Patients with ASD have a very heightened drive towards pursuing their restricted interest, and some struggle to motivate themselves to do anything that is of non-interest. and non-cued routine. So ADHD patients similarly show strong reward seeking and apathy and effort regulation difficulty when embarking on low reward activities. Both are prone to addictions, substances, and behavioral. Are there any studies that could inform models of motivation, reward, and effort regulation in ASD and ADHD?
I'm not an expert really in these areas, but I think what it really speaks to is, of course, the experiments I showed you here were for monetary rewards. And what might be really interesting is rewards that are found to be rewarding to a particular individual. You know, money might not be the motivation factor for some people, but a drug might be, or the restricted rewarding outcome that someone with ASD might have. So we've been thinking about trying to tailor the reward to a particular individual. And actually our colleagues in the Salpêtrière in Paris have just published a study in Brain on frontotemporal dementia, where they used stimuli that were rated to be highly rewarding by, you know, their patients, but they didn't use stimuli that were of not really significance to them. So that might be a way to go, is to tailor the experiment to the particular outcomes that you find rewarding. And that might be a way to explain what you're trying to get at, I think.
I have one last question, almost in time arrival. So the question is of Oliver Harmson, and the question is, where next with the serotonin research in apathy? Are there any plans to trial SSRIs or selective serotonin agents for apathy?
Yeah, there are plans. Indeed, there are plans. We did a little pilot study, Oliver, in Parkinson's disease patient. Lisa Nobis did this, where she put them on citalopram for 5 days and versus placebo, again, counterbalanced. And she found that citalopram actually worsened motivation on the task that I showed you, the apples task I showed you, in people who already were apathetic prior to the introduction of citalopram, but it improved motivation in those who weren't. And this is actually echoes some clinical experience that sometimes SSRIs can make apathy worse in those who already have it. Now, of course, you know, SSRIs are a blunt instrument because we're affecting all sorts of serotonin receptors with that. But there are plans for sure, yeah, and I think it's a really interesting area.
Thank you so much. It was a wonderful talk, Masud, and everyone really who commented was enjoying it very much. And thank you all for attending this seminar.
Thank you.